Hi, my name is Dr. Robert Kaufmann, and we're about to go beyond the terminus. Pulp tests are an important part of the diagnostic process. For many years, endodontists used to use the terms vital and non-vital for the condition of the pulp as tested with pulp tests. Many of us still use them today. The clinical assumption is derived from the responses to the pulp tests that we perform. But as my friend, the late Dr. Joseph Tufkin, was fond of saying, it's more accurate to label the results of these tests as either responsive or non-responsive. We cannot correlate the histologic condition of the tooth merely based upon pulp tests alone because of the variability of pulp tests results in individual teeth and their lack of predictability. We can say that a responsive tooth is more likely to have a vital pulp. However, a non-responsive tooth may have a necrotic pulp, but it also may not be responding because we are unable to transfer the necessary stimulus to the pulp to get a response. This is an important consideration whenever we perform pulp tests as a diagnostic procedure. Standard tests for pulp vitality are thermal and electric. Thermal tests are performed with Endo ice as a cold stimulus or an ice pencil, and another thermal test that we can use is heat with a generating material such as heated dental stopping compound or heat tests with hot water. In specific cases, where the patient reports sensitivity to liquids, it may be more effective to place a rubber dam on each tooth individually and then bathe the tooth in either hot or cold water to attempt to reproduce the patient's symptoms in the chair. In all cases where patients are symptomatic, it's important for us to reproduce the patient's symptoms exactly in the chair before we consider any type of intervention. For many years, electric pulp tests were a common procedure used to try to ascertain whether pulp tissue was vital or not. Electrical stimulation of the pulp, supplied by means of a dedicated pulp testing device, was used to attempt to stimulate the pulp for a response. Difficulty with this device is that if the current is sufficiently large and is toward the high end of the scale, sometimes the sensitivity of the PDL can be misinterpreted by the patient as a positive pulpal response. Electric pulp tests also cannot be used through restorations. The ability to transfer sufficient current to the tooth to get a response also depends upon several factors that include the amount of contact that the actual device has with the natural tooth structure, the amount of pulpal recession, the secondary calcification, and frequently the age of the patient. Elderly patients tend to be less responsive than younger patients with larger pulps. My referrals will frequently send pulp tests with numerical values when they refer their patients. The amount of electricity applied to the tooth is usually displayed by means of a 2-digit number. While this may be well-meaning, it really doesn't provide much information other than the fact that the pulp showed either no response at all or at least some response. Unfortunately, the way that these devices work is frequently misinterpreted by users. Clinicians often misinterpret these numbers to mean that a higher number value, for example, means more current that correlates to a pulpal condition. They assume that because the number value is higher, the pulp is further along in the pathologic process, or it's less responsive. This is a misconception that can lead to errors in diagnosis. The only information that can be gained from an electric pulp testing device is the possibility of either a response or no response. Yes or no. And even this may be a false positive or false negative depending upon the case. There's no gradient that can be correlated with any numerical value. In other words, these number values cannot be used as a measure of how sick the pulp may be. Younger patients with open apices who undergo trauma of anterior teeth can have unpredictable pulp responses immediately after the trauma. Rather than risk doing endodontic procedures immediately, it's sometimes best to have a watch and wait attitude if the pulp tests don't produce consistent or expected responses. If an incompletely developed traumatized anterior tooth is incorrectly diagnosed with this, the clinician may incorrectly access the tooth and risk removing vital pulp tissue, which is necessary for further formation of the root and closure of the apex. This clinical error has the potential to affect the long-term outcome of the tooth. The ideal pulp test machine would have only 2 lights on it, one red and one green. The red light would indicate full-scale maximum current has been transferred. And if the patient did not respond at that point, we would suspect that the pulp might be non-responsive. If the patient responded at any point before full scale with a green light, we would have to assume there's at least vitality in some degree in this tooth. We would still be unable to tell the exact histologic or pathologic condition of the pulp by the test, and false negatives can be common, especially in heavily restored teeth. Just because the patient is non-responsive to the electric pulp test doesn't necessarily mean that the pulp tissue is necrotic. At that point, we have to fall back on the old gold standard, a cavity test. If you want to learn more about that and how I do a cavity test, please check out my other Beyond the Terminus video that addresses this specifically. I very rarely used the electric pulp test over 20 years because I find the test to be unreliable. I'm frequently treating teeth that are very heavily restored, that have been previously endodontically treated or accessed, and that require elective endodontic treatment for prosthetic reasons. CBCT imaging has also been extremely valuable in helping determine whether periapical radiolucent findings are present that are suggestive of a necrotic pulp. However, clinicians should have an EPT in their tool bag if it is required. When in doubt, I prefer to go to the cavity test, which in my opinion is far more reliable. In the case of a necrotic pulp, the dam is already on, and we can proceed with an endo treatment immediately. In situations where we get a positive response, the pulp is vital, or when no response is expected, and we do get a vital response, we can then quickly restore the tiny area of the cavity test and the sensitive tooth and refer the patient to the appropriate specialist for further evaluation and diagnosis. Remember, when we do the right thing, we both get better, patients and clinicians. Please don't forget to subscribe. This channel is free. Tell your friends and colleagues. Thanks for watching. I look forward to our next trip when we go beyond the terminus. See you then.